Good morning. Thank you for inviting me to speak. It is an honor to speak to all of you. Like most of my talk has probably been addressed, but I'll give some highlights on more the inherited part of prostate cancer. So just as a background, so the majority of the prostate cancers is still sporadic, it's not inherited. Only about 5 to 10% of the prostate cancers will be hereditary, where we will actually identify a known cancer-causing gene. And then we've got this 20% group where we know it's familial, we see there's lots of individuals that's being diagnosed with prostate cancer, but we cannot identify the gene. And I think this is more so in our South African population because we do not have enough studies yet. So I'm going to focus on the ones that we know of. So of these, HOXB13 is the one that we should all know about. It's the highest risk prostate cancer gene, and it usually occurs in men of a younger age. And there's no other cancers that's associated with these genes that we know of, and the lifetime risk for a man would be about 52% if they carry this gene. Then we all know about the BRCA1 and the BRCA2s. So very important, BRCA1, the lifetime risk is about 29%, and for BRCA2, it's about 60%. And that's especially true on our BRCA2 founder variant that we have in our population. And then also to note all the other cancer risks that's associated with this. It is a high-risk breast cancer gene, not only for women, but for men as well. And then you'll see ovarian cancer and pancreatic cancer, and melanoma is also something to note. Then our Lynch syndrome. Originally, we thought that Lynch syndrome is not associated with prostate cancer, but we have new data suggesting that it is, especially the MSH2 gene. So this is also important in our prostate cancer patients, because once again, this leads to a whole range of other cancers like colorectal cancer for the men and endometrial for the women, for the family members of the men. Then there's a whole list of other genes that I'm not going to go into. The data is still very new, it's very preliminary, but we know there's a strong association with the ATM gene with a lifetime risk of about 44%, and we don't really know what the lifetime risks are for the other genes, but we see that there is an elevated risk. And as research is continuing, we're adding more and more genes, like Gen1 and ATR has recently been added. So just to always explain the difference between germline variants and somatic variants, which has already been addressed, very important, germline is something that you are born with. It's in every single cell of the body. And if you look at somatic, it's something that occurs at random and because of outside exposures. It's not in every single cell of the body. With germline variants, if you do germline testing, you can use a blood sample or a saliva sample from an infected or unaffected person. Somatic testing is usually done in an affected person. The purpose of germline testing is to identify inherited causes, to identify the risk for future cancers, and also for the family. And then somatic, the purpose is more to identify therapeutic options and to determine the prognosis. Germline testing, it can predict the risk for future cancers and for the family members. Somatic, it cannot predict the future risks. So with germline and somatic, I always just highlight this to show you that with the BRCA1 and the BRCA2 genes, it would usually be, if you find a variant, it's usually going to be germline. But with things like P10 that was mentioned, it's mostly not an inherited variant. So it's mostly on the somatic tissue only, and the same with TP53. So why is this important? Because obviously when we have to decide between germline and somatic testing, so with our germline, the highest frequency is obviously in the metastatic patients, and the same with the somatic. So this is now all the actionable genes. They actually say that in about 89% of the metastatic castration-resistant patients, you will find an actionable genetic mutation, but only 9% of those will be on the germline. So it's always important to consider this. So why is this important? So it determines the disease progression and prognosis. So there's been quite a few studies on the BRCA genes and the ATM to say that those cancers are more aggressive. It leads to an earlier diagnosis. It's usually lethal or a higher chance of being lethal. And then also there's been additional studies being done, and they found that there's other genes that's also significant in progression, and there's 5 of them that's being highlighted: BRCA2, ATM, CHEK2, PALB2, and NBN. And interestingly enough, all of those genes I've already seen in our population. Not so much the PALB2, but the others are quite prevalent. It informs the management and therapeutic options, which has been outlined with the previous talk. So it also helps with decision making, because even if you've got an early stage disease patient, if they have one of those high-risk genes, you would actually have a lower threshold to do a biopsy. If the PSA increases during active surveillance, you'll do more frequent active surveillance, and you also have a lower threshold to actually start treatment for that patient. For the intermediate and high-risk disease patients, you have a lower threshold to actually start more aggressive treatments than you would usually have. And also, it helps to identify whether this patient is a candidate for targeted therapies. They've spoken about the PARP inhibitors for the HRR genes, but also to mention that there is the immunotherapy options for the Lynch syndrome gene, so you actually also want to know about that. This is just a nice summary that I found that sort of gives you a list of all the genes and the therapies that has been approved. So you'll see there's quite a few genes that has been approved for the PARP inhibitors, and then also ones that show response to immunotherapy. It's important to be aware of these genes because you have to know this when you're deciding on your genetic testing. It also identifies hereditary cancer risks. So I'm going to actually use an example to illustrate the benefit of this. So as a case illustration, I met with this patient, Mr. A. He was diagnosed with prostate cancer at the age of 61. He is of Afrikaner ancestry, and if you look at his family history, he has a mom and a sister who was diagnosed with breast cancer. His brother has pancreatic cancer, so it's really very suggestive of an inherited genetic mutation. We did the testing. I used international testing that looks at 84 cancer genes because there was a variety of cancers in this family. And I found the common Afrikaner BRCA2 mutation. So what does this mean for him? So it does mean that if his prostate cancer progresses and it does become metastatic, he would be a candidate for a PARP inhibitor. It also means that he's at an increased risk for breast cancer, so we have to do annual chest examinations, and also he has to do monthly self-examinations of the chest area. He's also at a slight increased risk for skin cancer, so he has to do annual full-body skin examinations with a dermatologist. He's also at an increased risk for pancreatic cancer, and the newest guidelines say that all BRCA2 positive individuals should have annual pancreatic imaging starting from the age of 50. This is also important for his kids and the rest of the family, and since I did testing through the in vitro laboratory, I could offer them free of charge testing, because it's not really free, because the local laboratories charge for the courier fee. So I used Pathcare, so it was 1,200. And these are all the family members that tested positive. So you can see it's a lot. So what this means for them is just a reminder of what the risks are. For the women, so for his daughters and the rest of the family that's female, they have very high risks for breast cancer. It's up to 80%. So they would qualify for prophylactic mastectomies if they are of the appropriate age. The same with the ovarian cancer risk is as high as 46%. So when they above the age of 45, we would also do prophylactic BSOs. And then for the men, the male breast cancer risk, as I said, the risk is about 6 to 8%. So we'll have to do the annual screening for that. And the pancreas is up to 9% in comparison to population risk of 1%. So annual surveillance for that as well. Very, very important. We often forget about the autosomal recessive conditions that's associated with these genes. We're very much focused on the cancer risks if you're a carrier of only one faulty gene. But if you are a carrier and you're planning to have kids, and your partner also has a very strong family history of cancer, it's important to have that partner tested, because if that partner is also a carrier for a BRCA2 gene, there's a 25% risk of having a baby with Fanconi anemia. And this is a serious condition. I mean, it does lead to cancers at a very young age. And there's reproductive genetic testing options that's available to either prevent this in a future pregnancy, you can use the IVF route, testing the embryos and selecting the ones that's not affected, or testing a pregnancy. So who should be offered the testing options? So I used mainly the NCCN and EAU guidelines, and then I've added a little reference there for you that sort of uses all the guidelines and puts it together. So for men who are affected with prostate cancer, you would offer this testing to anyone that's below the age of 55. But there are some guidelines, like the Swiss guidelines, that say you should offer it to anyone that's 60 years and younger, and I think that's probably what we should be doing in our country. Anyone that's been diagnosed with metastatic high-risk disease, intermediate risk disease, and anyone who's been treated who has a biochemical recurrence, anyone who's had another primary cancer, or anyone that is of Ashkenazi Jewish ancestry, because we know 1 in 40 Ashkenazi Jewish individuals will carry either a BRCA1 or a BRCA2 mutation. The Afrikaner ancestry is also important. I don't know what the carrier frequency is, but we do know that it's increased. So that's why I add Afrikaners to our guidelines. And unfortunately, we don't know what the founder mutations are in the Black African population yet. And then for all men, whether they're affected or unaffected, you would offer it if there's a strong family history of prostate cancer, especially if it was metastatic, if it was diagnosed at an age younger than 60, or if they've got several members who have actually passed away from the prostate cancer. Anyone who has a strong family history of cancer, not only prostate, but all kinds of cancers, especially like your colorectals, ovarian, breast, pancreatic. And then obviously you would offer anyone testing if there's a known familial mutation. So for the somatic genetic testing guidelines, it looks a bit different. They say all men with metastatic prostate cancer should be offered this choice, regardless of their age or family history. The only exception would be is if a germline mutation has already been identified. What should the testing include? So they say you should be testing for the HRR genes, and that is the list of genes that HRR test should at least include, because the PARP inhibitors are approved for all of those. Whether it will be funded in our country, I'm not sure. For BRCA2, yes, but we haven't had other patients with other mutations, so we're not sure if that will be successful or not. It also says to look for microsatellite instability and mismatch repair deficiency for the immunotherapy options. If any of these mutations are identified, or whether the tumor is suggestive of Lynch syndrome, they actually recommend referring to a genetic counselor to assess the familial risk. So what testing should you be doing, and when should you be doing it? So there are like several germline genetic testing options available in South Africa. And I think it's up to the patient, it's up to the context, and would they be able to afford it. So BRCA1 and BRCA2 founding mutations is always an option, because it is the cheapest option and it has a very quick turnaround time, but it's not comprehensive. It's only going to look for 7 mutations in those genes, and we know there are several. You can do a single gene full screen, so you can pick a gene and only do that one, but I wouldn't really recommend that because it's very expensive, and you'll see the cost of the full gene panels are similar. So why do only one gene if you can do all of the genes for the same price? So in South Africa, we've got a lot of the local laboratories that is offering testing, and very important, the medical aids do cover the cost for germline testing with motivation. So it's not self-funded, but it is the South African options, not the international options. Our South African options are limited because it does not include all the known prostate cancer genes. You usually use your breast and colon panels for that. So the international tests, they are the preferred tests, but it's out-of-pocket payment. And the cost has come down. It used to be 30,000 Rand a few years ago. Now we're looking at about 6,500 to about 7,000 Rand, which is affordable. And the other nice thing about some of these laboratories are that if you identify the cancer-causing mutation, you can get free testing for the family. So sometimes you can have a discussion with a patient and say, maybe you've got wealthy family members, maybe you've got lots of kids, so they could all pitch in to fund the testing. So when you're selecting a test, once again, make sure you're including all the genes that's relevant. Okay. For somatic genetic testing options, so there's once again quite a few, but I just want to mention two because I think these two are quite helpful. So Pathcare does have a smaller panel. It's a BRCA Plus panel, and you can see it includes most of the HRR genes, but once again, not all of them. That has been approved for PARP inhibitor treatment, but it's a good alternative because you might get it medical aid funded and it's a lot cheaper. And also if they find a BRCA1 or BRCA2 mutation, they'll do the germline testing for free. Then they've spoken about the OncoMind Comprehensive Plus. This is always the preferred test, but the cost is a downside. It is over 42,000, and it's once again upfront payment from the patient, and then they can try and claim it back from the medical aid. There has been some success, especially if it's a comprehensive medical aid plan, but not always. So how do you decide between the two? So just to say a little bit of a disclaimer, so this is my opinion, okay, from all the reading that I've done and working in the field, but it's up for discussion. So once a patient is diagnosed, they recommend, if they meet the testing criteria, that you do the germline testing first. Why is that recommended? Because if you find a mutation here, you stop. You don't have to do somatic testing. But if you find it on somatic testing, you have to proceed with germline. Also, if you don't find it on your somatic testing, you have to do germline. So that's why they say, if you're thinking about cost effectiveness, start with a germline. Also, the medical aids are more pro to fund the germline testing. So if it's positive, then you don't have to do somatic testing unless you are looking for alternative options. Because remember that PIK3CA is not on this. All of those alternative therapies you can do, but you can delay that testing until a later stage. If it's negative, you ask yourself the question, is it metastatic? And if it is, you have to do the somatic genetic testing. If it's not, you can actually defer the somatic testing until a point where it becomes metastatic, because we know that our cancer cells with treatment, the mutations change. So if you do it too early, it might not be representative of the metastatic disease. Other things to consider, timing. Is there enough time to do both? Because germline genetic testing takes about 2 to 3 weeks if you use the international lab, but it takes about 5 to 6 weeks if you use local laboratories. Is there enough time for the NGS testing? Because that will once again take about 2 to 3 weeks. So is there enough time? If the funding is available, you can do both at the same time. Funding needs to be considered. Can the patient afford it? Can the patient afford the treatment? Because if they cannot afford the treatment options, you rather want to stick with the germline because you actually want to then prevent the cancers in the family members or prevent that patient of getting future cancers. What are the guidelines? Who should be tested? Who should not be tested? What does the family look like? And also the accessibility of the tumor tissue. Are you able to get a sample to do the somatic testing or not? Once again, this is up for discussion. So take-home message, so consider genetic testing for all young men with prostate cancer or anyone who has a strong family history of cancer. Test all men with high risk or metastatic disease. Use both the germline and somatic approaches, whichever is appropriate, and then interpret the results in the context of treatment options and also the family. Because just to highlight with that point, remember if you're seeing an individual with a strong family history of prostate and that person is also affected, if the genetic testing is normal, that family is still at high risk because we have not yet identified all the causative genes. And then also, if you are in doubt, collaborate with the genetic services or the genetic counselor. They are there to assist you and to help you make these decisions. You do not have to make it on your own. So I'm going to leave you with this last slide with the contact details of all the practicing genetic counselors in South Africa. And then you've also got my details if you've got any questions. Thank you.